Thanks, Gary, and good afternoon, everyone. So let me just start by giving you my perspective. I always like to throw in definitions. So from my perspective, this is my definition of systems thinking. I'm not quite sure where I got this from. I stole it off the web and edited it several times. So it's the idea is just to point out that systems thinking is an approach to trying to think about how things interact with one another. And I think really that's the purpose of our discussion today. And also to talk about health from a systems perspective. As you know, we spend a lot of time talking about patients and by the ones and the twos. And what I want us to begin thinking about, at least for this presentation, is the impact for larger groups of patients. And for the purpose of the health system, to be as broad as possible, not just to think about what happens to individuals, but what happens to the systems that support them, the information systems, the facilities, the way ambulance systems work, and again, of course, how they impact the health and well-being of populations. So clearly, we've talked a great deal today about the fact that climate change impacts the health sector. I'm going to talk about various, primarily major events that have happened over the last several years. Obviously, none of us can argue that any particular event is a result of climate change, but we are seeing these come up more and more with more regularity. And so I want to talk about them really fundamentally through these four lenses: and extreme weather, poor air quality, climate-sensitive diseases, which the panel was just talking about a great deal, and broader environmental change. So let's talk about the EF5 tornado that hit more medical centers several years ago. And this is just a picture of that hospital. Moore, Oklahoma is a relatively small community in Oklahoma. It sits really outside the urban setting, so it's not that far away from the urban setting, but the fact is this tornado, frankly, leveled the town. And there was certainly a direct health impact for the tornado. They had a fair number of patients that ultimately got treated in hospitals. Tragically, they had several deaths. The medical center was heavily damaged. That's the key word that people talk about, heavily damaged, but they had to build a new hospital. And they had to then relocate many of these patients to Norman, Oklahoma, and another hospital. Let me tell you that I spent many of my years practicing emergency medicine. There's a concept called transfer trauma. So even when you have patients who are not ill or fundamentally sick and they have to be moved from one hospital to another, there's actually a morbidity or mortality of actually picking up a patient and moving them from one point to another that often doesn't get measured when we talk about these kinds of events. So it's just important to know that there is something that happened. These are certainly the direct health impacts, and these got counted. Everybody measured them. They got reported in the news. FEMA certainly counts these numbers, et cetera. But what often doesn't get thought about, of course, is what happens afterwards. The fact that they had certainly the loss of a 45-bed hospital with emergency services. What happens the next day to those patients who have heart attacks or asthma, who actually were able to stay in the community? Granted, this community was fairly well devastated, but there certainly were people that were around. They did have to rebuild the medical center at a cost of about $29 million, and that has occurred. They were fortunate that this hospital was part of another major hospital system, so they were able to deal with the personnel impact of moving people around. But that often doesn't get measured in our modeling. We often don't think about what happens to the employees in these various systems that have to move around. And people often don't think about the access to care, particular access to care that occurs when this kind of devastation occurs. I remember that I was a health officer and health secretary for the state of Maryland when we had a tornado that went through southern Maryland. And I can tell you that it was terrible. People lost their homes. But what was most impactful to me, just watching as a state health official, was the enormous mental health impact on officials, not just the people who had lost their homes that the officials were trying to manage, but what's fascinating to me was the mental health impact on those officials who were trying to all have a stiff upper lip, trying to maintain some degree of assuredness in front of the television cameras, and yet they had lost everything. You also saw that in after Katrina. Actually, American Public Health Association actually did a book where we captured the stories of the medical providers that responded to Katrina. And think about it. You get in your car and you drive 2 hours, leaving your family who've now been relocated outside of Louisiana, and now you're going back each and every day trying to take care of people, and the stress and strain on that. We never capture that in terms of dollars or in any of our modeling that we do about the impact. We talk about the direct impact, but we never talk about these tail events that occur when something like that happens. 1995, I actually grew up in Chicago, so I was around during this time. As you know, we had a fair number of people who died in this particular heat wave. What's always fascinating is the fact there were also lots of ER visits. We always have these predictions with heat. We know that a big one day of heat is not such a big issue. You know, the temperature goes up to 105 for one day. That tends not to be a problem. It's when it's 3 days or 4 days. And now with much better weather predictions, we now can predict that we're going to have a real challenge, and we know the weather is going to be very high. In Chicago, of course, they had significant racial disparities in these deaths. There's some debate about that, but the data, I think, in retrospect, is pretty clear that those disparities did occur. You heard from the last panel, which was just beginning to talk a little bit about the societal issues that need to be addressed. Here's an example where there was an opportunity, at least in retrospect, to go back and look at what some of the social determinants of health were that impacted that. In those days, we had lots of high rises in Chicago. The good news is a lot of them are down now, are gone in low-income communities. We've moved those people out to the suburbs. That's a different issue we have to address, where there's not a lot of resources. Lack of air conditioning, because these tended to be in low-income, in some cases, high-crime communities. Seniors were not about to come outside at night. A lot of the doors were either painted or nailed shut, the windows, I should say, and so people couldn't, open their windows. And in retrospect, the government was criticized for being a little slow. We've learned a lot from this. There's great plans in place now. Most big urban settings respond in a much different way than they did back in 1995. Much better targeting of where the vulnerable populations are, getting people out, getting them to cooling centers, getting them fresh water. But, that's still a big challenge. I suspect there's still many cities that haven't quite learned this lesson. We have this tendency to forget these lessons as elected officials and others begin to rotate around. They pretend to lose these lessons. We're going to hear a little later about community design, but obviously the heat island effect of a big city certainly does also play a role in something like this. I think the important thing is that we can both proactively and retrospectively model some of these kinds of things by simply changing some of the parameters. What do you do if you know where all the vulnerable populations are? Can you reduce morbidity and mortality? What happens if you don't know? What happens if you only know where 10% of them are? What happens if you know where 20% of them are? What happens if you do this and you know where they are, but the electricity goes out and you can't get them out of the buildings because the elevators are gone? Those kinds of things are very important things that we can think about from a systems perspective and begin to model. Major ice storms. We just recently, of course, had one earlier this year. The usual stuff with in terms of direct health impact, the falls and back injuries from people out shoveling snow or removing ice, more vehicle crashes certainly, and increasingly this is occurring in parts of the country that aren't used to dealing with ice and snow. We always know that we have an increase in frostbite and hypothermic injury, but as you know, in many of our parts of the country are now beginning to see colder temperatures with a great degree of regularity. We've not built those homes so that they can actually deal with these kinds of huge changes both in heat and cold weather. Every year we always have to deal with an increase in people dying from carbon dioxide poisoning, either because they brought in portable generators in their homes that are generally gas-fired because the electric generators go out, or they decide to cook using these gas stoves in their homes. And that remains a big issue when you start losing from a systems perspective. Again, you begin losing the power. When you have big facilities, generally the backup generators work, but we still have, as we begin to move many, many more people out of the hospital, so we've begun moving people that we used to keep in the hospital, we now keep them at home. And we now keep them at home with fairly sophisticated equipment, respirators, oxygen-powered equipment, all kinds of things that theoretically they need to have backup generators for. In most cases, there is some regulatory requirement that they have these things in place, but not always. So when the power goes out, there are real challenges. And again, knowing where those vulnerable populations are is important, but we don't always know where they are. They also result in huge barriers in access to care. Again, transport challenges when you have the ice. When it's icy outside, not only cars cannot get around, but ambulances and transport vehicles can't get around as well. And that's a big issue. We recently had to deal with Superstorm Sandy. Again, the direct impact was certainly the fact that we had some people died in New York. We did have to evacuate some hospitals. Again, the whole issue around transfer trauma plays out in a facility like that. They were much better prepared in New York than the challenges we had with Hurricane Katrina, but even so, they had some significant challenges when they went to evacuate patients. Lots of pictures around the net of people evacuating in flooded streets, ambulances not being able to get around in flooded because of the flood. We saw mental health impacts in New Jersey, where you had reports and studies that have been done that actually reported increases in anxiety and depression and post-traumatic stress. All of the things that I saw back when I was the health officer in Maryland, we saw in New Jersey after Hurricane Sandy. This is an organization that actually did a study looking at Medicare claims. We were the last panel talking about data. There's always opportunities to look at some of this data, and they found certainly an increases in the need for mental health services. Mental health is a major problem after all of these events. We really model those. SAMHSA, the Substance Abuse Administration, and HRSA always are very much involved in addressing these after the fact, but they really get modeled. There is always planning for these disasters within many of our disaster plans, but I got to tell you that they're rarely adequate in terms of resources or actually the planning that goes along. Some cases it's not as predictable as we would like. We would like to know a lot more about how these things occur. So what do you do when you're working for the fire department and your fire station gets flooded? We saw that during Hurricane Sandy, where we had 4 of the 5 EMS stations in Manhattan that were unable to actually use those places as a base of operation. That's a big deal. That's where your radios are. That's where you sleep. That's frankly your home if you're a first responder EMS provider. What do you do when you have to fight a fire in these kinds of crazy environmental conditions. Fire departments are very, very good at what they do, but there are real challenges, particularly in the urban setting when they try to do these things. And what's often not recognized is the significant loss of infrastructure that occurs. We build these systems for just-in-time management of the mean. We don't build them for extreme events. And it's too costly to do so, and so we don't do that. We build them for about the mean. And then when we have a very brisk response, the idea is that everyone from the surrounding areas will come in and help. But what do you do when you have a regional event of the size that we had with Hurricane Sandy? And these things happen with some regularity. I mean, I remind people that in Washington, D.C., when you talk about disasters, we had not only a snow during the Air Florida crash we had here in Washington, D.C., and we had Washington, D.C. and Maryland all responding, but we also had an Amtrak crash and we had a snowstorm. So these things do happen, and they do happen with some regularity in a very, very complex manner. And we often don't use the amount of imagination that we can when we plan for some of these events. I think the biggest impact of all of these types of things is the loss of access to primary care. We never think about the loss of primary care systems. The fact simply the loss of prescription services. What happens when you lose all the pharmacies? During Katrina, of course, they didn't have electronic medical record systems, and they had providers spending a lot of time sitting down with patients who've all been relocated out of New Orleans, and the patients would sit there and say, okay, well, doctor, I know I take a blue pill, and I take 3 green pills, and I take 2 white pills each and every day, and I think I got a little bit of sugar, and I think I got a little bit of high blood pressure. And the doctors then, of course, are trying to reconstruct that. Now, New York City, actually during Sandy, they had put in a fairly robust electronic medical record system, so they were able to actually mitigate a fair amount of that problem after Hurricane Sandy. And we're going to see more and more of that as we build our national electronic medical record system. And that will recreate the capacity to link patients to their records and to follow-up care. But even so, the actual loss of patient care provider offices, the bulk of our system is still a cottage industry where clinicians have individual offices. And when you lose that capacity, you lose that capacity. In New Orleans, providers obviously moved totally out of the city. And then some of them migrated back, and some of them didn't migrate back. So there was absolutely a loss of capacity overall. The real challenges around reduced air quality. We know that there's significant direct health impact from air quality, and we could debate that, but I think that is settled science. Whether it is simply smog and ozone, and the fact that we have many, many more asthma attacks and many more people with chronic obstructive pulmonary disease that get sick. We have code red days, and those are great that we announce those when we have code red days. We still have people that go out and, of course, mow the grass, and we have heart attacks. And those are certainly some of the direct health impact that we have. But again, not modeling what happens on those days. Again, when I was practicing emergency medicine, actually on the code red day, we actually had less people in the emergency department. We had someone who was out mowing their lawn who had a heart attack, and we saw 1 or 2 of those. It was always a day afterward where people began flooding into the emergency department, not only with their injuries, but the fact was their primary care doctors' offices were just inundated because of the illnesses they had suffered the day before, and now they're coming to the hospital emergency department. They didn't want to go out, it was too hot, so they spent the last 24, 48 hours wheezing at home, and now their asthma has gotten so bad, or chronic obstructive pulmonary disease, that they now need to be cared for in the hospital emergency departments. And we don't look at that as robustly as we could, and how these things are getting worse over time as our climate is changing. You recently had a very robust discussion about climate and disease. Let me just again point out that you know, we have lots of stuff that we can model. There are lots of opportunities to do so. I agree with the last panel that that data is something that we're going to have to pay a lot more attention to. Just to say that there are enormous opportunities for us to do that and look at it through data systems. We spent a lot of time as we were thinking about bioterrorism, and I would just commend you to look at some of the bioterrorism surveillance systems we did. Yes, we tracked, and we're doing it in the Washington, D.C. area, tracking stuff that goes off of the shelves in our grocery stores and many of our other systems. One of the challenges that we have, I think the biggest challenge that we have to successfully model through health systems research, health stuff, is that we're always 3 years in the rear. Until we stop looking at infant mortality 3 years in the rear, we're never going to catch up. You know, the grocery store in this region, Giant Food Store or Walgreens, they can do real-time monitoring of the stuff off their shelves. So I can tell you that if you're really looking for an episode of diarrheal disease, you're going to be much more effective looking at medications over the counter than you are actually tracking the disease. You're going to be 3 years in the rear looking at it. And so we're going to have to figure out how we do a better job of tracking health data. And we also need to figure out how we can link the health data to the school data, to this off-the-shelf data. I remember when we first did our first syndromic surveillance test in the Washington, D.C. region, and this is pre-9/11. And we were looking at, we had set up a system in Maryland and the Washington, D.C. area looking at school absenteeism and influenza. And interestingly enough, we were able to predict when the flu entered the Maryland community. We had that, and then we had our lab surveillance system, which is fairly real time, actually able to pick that up. And then, of course, we suddenly lost all the data because we had linked it very strategically to school absenteeism when all the elementary school kids went home for Christmas. All right. And then we picked up all their parents getting influenza when the kids came back to school. And we started looking at the kids and comparing it to adult data. So the discussion earlier about data changes, you really need to know at the local level what's going on when you look at that data. And I just put in a plug again for this goal that we're going to gather all this data at a national level, and somebody in some place remotely is going to be able to know what this data means. And until that data has been looked at and validated at the local level, you're never going to find out these subtleties, such as the schools closed that day because of a holiday, or they took off because it was, you know, parent-teachers day, or you're going to lose data sets. And so you're going to have to build all that kind of stuff into your modeling as you go forward. Obviously, broad environmental changes are very important, whether we're talking about drought or food insecurity and all the things that happen when you have these major events that occur regionally, anywhere around the world. And there's obviously significant health system impact when this happens, where you have civil unrest and violence, the long-term psychological trauma that occurs with that, the violence that occurs with that, and the injury, managing the refugee help, managing migratory health when people move from communities such as we had in New Orleans, such as we had to some degree in the New York region when people had to leave parts of New York. Those are real challenges. And again, this looking at the loss of continuity of care of the individuals. Again, we don't tend to manage those as we're doing the health systems research stuff. So just to put some opportunities out there based on these concepts that I'm trying to sell you on today, is that there are some opportunities, I think, for us to do things such as tracking health infrastructure loss and looking at how access to care changes under these models. Clearly looking at the social determinants, particularly in the way of mitigating things that happen as we go forward. Imagine, for example, under access to care, just modeling the fact that what happens if you lose 10% of your mental health capacity in the community and your need goes up 10% based on an event. That's be an interesting model to know. And what do you do about that? How do you mitigate that? How do you build in systems so that you can prevent that from having a huge impact on people? Looking at community design and the health effects are going to be very, very important. Again, I think Dick Jackson's going to talk much more eloquently about that. And then looking at the stress on the public health system. You know, again, we build these systems for what happens right there at the medium, and we don't look at these things what happen at the extremes. And we ought to look at what happens when our systems get broken. When a hurricane or a tornado takes out our infrastructure, what happens? What does that mean? What does that do long term? What are the costs to that? You know, if we built these facilities differently, so they were much more resistant to some of these storms, would that be helpful? You know, how do we look at the costs of that? What happens when someone has to now travel an hour to get the care they normally had to go for 15 minutes? Is there a health cost? Can we build that into our modeling as we go forward? Particularly looking at transfer trauma, what's the impact to patients and the cost of moving people from one hospital to another? And all the kinds of things that we think about that we know that happens to you know, vulnerable populations are going to be important as we go forward, including impacts around chronic illness. So with that, I'll stop, and here I guess I'll turn it back over to you.
So we have time for maybe one question. Yes, please.
Hi, I'm Amanda Stout from the National Research Council. So electric utilities are increasingly pre-positioning resources in anticipation of storms,
Yep.
right? And so I'm wondering to what extent the public health sector is thinking the same way, and to what extent improvements in this intersection of climate modeling and health modeling can help inform those decisions.
Well, you know, they do so for disasters. There is a fair amount of pre-positioning of materials in doing so. The challenge is in pre-positioning is they're not like doable generators. The challenge you have is medications, you know, very quickly meet their expiration date. And so we need to build systems that are standby, but that allow you to address building up either stockage levels in pharmacies. I mean, we've seen this with the National Pharmaceutical Stockpile. Very, very expensive system, which we have, but it is very expensive to move into a community, very expensive to open, very expensive to use. It takes 72 hours to actually get it initiated. And the truth of the matter is you need a system that's going to respond through the quote-unquote first responders, which means you really need to have that system very, very close to where the event is. We have not yet figured out how to fund that. So there's a lot of talk about it, but building those systems has a long, long way to go. Okay, thank you.
Thank you. Okay, our next speaker, Joshua. By the way, in terms of the last question, that's a perfect question to even follow up during the panel discussion, because it touches the topic of how do climate models and emergency management models, how do they interact? So the second speaker, Joshua Elliott from University of Chicago in Argonne. The title is Systems Approach to Climate Change, Agriculture, and Human Health. The floor is yours.
Thank you.